So here's our antibiotics that happen later. This is when we have a necrosis of some sort, right? The necrosis can be walled off. Usually gets walled off at 4 weeks, but before 4 weeks, 10 to 14 days, 21 days maybe, that is where we start getting necrosis occurring, and that necrosis can be sterile, right? But it can also be infected, and that requires surgery to fix it, right? We want to always do not damage control surgery, but source control surgery to remove the source of infection, right? So pancreatitis, it looks like sepsis, but is it an infection? No, right? 90% of the time, it's not infectious. The other 10% of the time, it could be necrosis, right? So 10%, and then we got 90%, right, is sterile. So we want to make sure that if we need antibiotics, that it is infectious, right? We don't just give antibiotics just because now they're going to have like a C. diff colitis on top of their pancreatitis, which is not great, right? And what's the treatment for this is going to be Zosyn. And does Zosyn cause C. diff? It is, right? So it has anaerobic coverage and has gram-positive and gram-negative. The gram-positive is our C. diff, it'll knock out. And the gram-negative will knock out the E. coli that's in the gut, and now the C. diff can proliferate if it wasn't already destroyed in the first place, right? So we want to make sure we are stewards of our antibiotics. They don't get resistances and also don't get complications of our antibiotics. So pancreatitis has a surge response. So here's our sepsis. Here's our surge. You can see all of these have surge, but it's the sepsis that is the only difference between sepsis and surge is that we've found an infection, right? And pancreatitis, you can see over here, is a cause of surge. Is the same thing as sepsis? It can be 10% of the time, but it's not, doesn't happen until like 10 to 14 days in. And we know that with research, a lot of evidence that we're not going to just throw everybody antibiotics their way at a pancreatitis patient. Okay, so 10 to 14 days later, they can develop pancreatic necrosis, and how do you know that's happening? They're getting very, very sick, right? So they were doing great, 8 days, 10 days maybe, and then all of a sudden they take a trip for the worst. Now they're on vasopressors. Now they are getting much sicker, febrile and such, and they have a history of pancreatitis, or they have an admission for pancreatitis. Well, shoot, let's go ahead and start some antibiotics, and that's where we do Zosyn. Okay, so ascending cholangitis we'll talk about. That's where you have a gallstone that's in the way of the flow of the pancreatic juices, which is why you got pancreatitis. And then it's also in the way of the biliary juices, right? The bile is trying to dump past that stone, and the pancreas is trying to dump past the stone, and it can't, right? But there's another duct involved. What's the other duct? That's the hepatic duct, right? And we're going to have all this fluid here should be somewhat sterile or clean, because right underneath this is the sphincter of Oddi, right? But the bowel can make its way up there, and you can have a little bit of non-sterile activity, and now we can have a ascending cholangitis, where everything starts rising into the liver, and when we look at the liver anatomy, you can see it has like a direct connection with venous circulation. It's only like 15 centimeters away from the heart, right? It might be even less. So it can easy for it to cause a severe sepsis. So that's why ERCP is recommended to take that stone out so that we don't have this problem in the first place. Okay, so what else? So we have a ascending cholangitis that we want to be alert to, and we'll look at labs for that. And when we talk about gallbladder stuff, we should be feeling more comfortable with ascending cholangitis and all the other choles like choledocholithiasis, cholelithiasis, and all those fun ones. And then what else can happen with pancreatitis patients? Or what are some exceptions that you would start antibiotics maybe early is if we have a concomitant infection. I mean, just do an infection at the same time. We have pancreatitis and a UTI. We have pancreatitis and a pneumonia. Then yes, we should start antibiotics early compared to waiting for 10 to 14 days. All right, the go-to one was Zosyn. It was thought to be that only meropenem penetrated the pancreas, and that was the one they used all the time. But if we can use something just a little less strong, and we have the same efficacy, then that's why Zosyn is there. Okay, so if they have this have an ascending cholangitis, we emergently need to do an ERCP. Otherwise, we can wait, and we'll look at the labs for that as well, right? It's basically when they get an ALOC and they're getting shock process, right, from a gallstone pancreatitis. That is really a patient that's probably at high risk for a ascending cholangitis. There's also T. bilis and alk phos we'll talk about as well. All right, but as we know, they can get a walled off pancreatic necrosis, which can develop a infection where we would need antibiotics and the overall course of their disease process. So they have this non-infectious insult, pancreatitis, right, which is causing surge, We got a temperature elevation, we got a heart rate elevation, a respiratory rate elevation, just need 2 of them. And that can lead to multi-organ dysfunction syndrome, which is off the page over there. Lead to MODS, which is very, very high mortality. And that can lead to a shock process. And yes, you can get infections also with pancreatitis. Yes?
Is there a reason that we would do ERCP over like cholecystectomy for somebody that has gallbladder disease?
So ERCP versus cholecystectomy. So cholecystectomy, they could get in there and find wiggle their finger down the biliary tract to pull it out, but ERCP is less invasive, and they're able to go in there and just kind of yoink out the stone. If the stone is super high, then they might have to then come from the other side, from the other side of the gallbladder, right? And we'll point that out. Like the gallbladder, sits right here, all right? And if we have the stone lodged right there, causing the gallstone pancreatitis. So could they take out the gallbladder? Yes, they could, and then they have to stick their little grubby fingers down there to yoink out the stone, right? So as far as like, is it easy or not, I can't tell you, but I imagine it's a little more tough you'd have to stick instrumentation down there to pull it out. As far as like outcomes, like which one's better, I would imagine ERCP is better because there's a better recovery time because you're not opened up, right? You're not getting anesthesia, you're just getting like a versed push, right, for the procedure. So that's kind of why they prefer ERCPs first over choles. But it is recommended to get a chole before you discharge though. All right, so infected necrosis, where is it at? So reverse precipitants, so I forget where I saw that at. But that is something that they would do as well, because if they got a gallstone pancreatitis now, they might get a gallstone pancreatitis in the future. So it makes sense to take out the gallbladder as well. Okay, so complications of pancreatitis. So they can get obviously infection that we mentioned, right? They can have swelling and necrotizing, which causes an infection. Swelling itself is just the pancreas getting bigger. 90% of the time it will get bigger and edematous, right? And hopefully it will go away. But if we start giving too many IV fluids, that's going to worsen the situation. And the SIRS process is really no joke. It can definitely cause your body to go haywire, cause you to have ARDS, cause you to have multi-organ dysfunction syndrome, put you in the DIC, AKI, shock process. So it's not something that we just need to take lightly. If they have hypotension and pancreatitis, we really need to get them better perfused to avoid these secondary injuries, right? And then pancreatitis itself can lead to, or acute pancreatitis can lead to chronic pancreatitis, all right, which we'll talk about coming up. We're going to talk about the differences between the two. All right, so what causes low blood pressure in someone with pancreatitis? So there's the surge response as well, as noted with just the cytokine release. And then there's third space losses. As I mentioned, 95% of your stuff gets leaked in the first place into your pancreas, which isn't great. But also the surge response itself and this widespread inflammation can also cause your capillaries to start leaking and leaking and leaking. All the fluid leaks, all the albumin leaks, and a lot of other things leak, even like RBCs as well. And I've only seen it like a handful of times. We had a patient recently where this happened to, where he injected meth into his arm and it caused him to have capillary leak syndrome all through his arm, and it just filled up a huge amount. He had compartment syndrome, and his albumin was like in the trash, like 0.2, right? Because all the albumin just dumped into his arm, and now you have no albumin to do what? What does albumin do? It holds all the water inside the bloodstream. So now all the water left, and now his hematocrit is like 64. So now his blood is like molasses, thicker than molasses. And now he has no flow to his heart, no flow to his brain, no flow to his kidneys. It's capillary leak syndrome is very rare, but it's extremely deadly. Okay, so other problems that can happen, you can have GI losses, so they have vomiting, diarrhea from pancreatitis. They could get a retroperitoneal hemorrhage if it's a hemorrhagic thing, and that's where you get your go-to colon sign and Turner sign. But abdominal compartment syndrome is also a real concern. If it doesn't cause localized leakiness around the pancreas, it could cause localized leakiness elsewhere, including the GI tract, and you can then have compartment syndrome, which is going to, or not compartment syndrome technically yet, but it can start compressing the vena cava and causing a lack of forward flow, and that's going to worsen your AKI and such. So that is important to consider when you have a belly that is firm and distended. With pancreatitis, we should be checking what to assess for intra-abdominal hypertension? That should be sure your bladder pressures, right, or your abdominal pressures. All right, abdominal pressures, your IAPs, your intra-abdominal pressures. And then cardiac output, because of that, could be low because of that, but just also from SIRS, inflammation, sepsis. It causes cardiac output to be hyperdynamic at first, right? Because your heart's going to react to this inflammation, but then later it disrupts normal function, mitochondria included. That's going to make your heart function reduced, right? And then at the same time, if we have increased IAP, we know that also is going to cause a decrease in cardiac output. And acidosis itself is not going to help someone's function of their muscles. All right, what causes hypoxia? So we talked about low blood pressure, but what about a complication of hypoxia and ARDS? Well, SIRS just straight up happens from ARDS happens just with SIRS response, right? Your lungs go crazy from this inflammation that's happening, and there's a localized inflammation, not in all the alveoli, bilaterally. So you have a bilateral pulmonary edema that occurs, all this effusion, the 95%, everything leaks into your alveoli on both sides, right? So we have a edema, a pulmonary edema that develops, and it's non-cardiogenic. The heart's fine. It's just the inflammation that caused this process to occur. Pleural effusions can happen. The pancreas, right? It sits over the epigastrium there, but also the left upper quadrant, right? So that localized inflammation can then leak across the diaphragm, make the diaphragm and that lung down there get inflamed, and then it can then start being leaky itself, and now you have an effusion that is on the left side. So left lower quadrant effusion is common with pancreatitis as well, and that could cause hypoxia if it doesn't progress to ARDS. And then pulmonary edema, as we mentioned, right? It's called pulmonary edema because of inadequate cardiac function, but also from ARDS. And then they can start aspirating. If they start getting the level of consciousness gets reduced, and we know vomiting happens like 85% of the time these patients. So if they're decreased ventilation, that can also put at risk for aspiration. All right, so this is all the things we just been talking about. They have a lot of pain. They have adrenal hypertension, necrotic pancreatitis about 15% of the time. Otherwise, it's usually just swelling of the pancreas. They got the surge response centrally here, which is going to cause a lot of problems. Just everything we talked about in septic shock is also going to happen in pancreatitis. All right, it's just as important. All right, so there's this BISAP score. We had the Ranson criteria before that we used in the 70s, but we have the BISAP score, which is a newer score to predict mortality. So it's just going to get, the only reason I put it there is so you can recognize the labs and changes that might happen, right? Your BUN and creatinine might elevate. You'll get ALOC. You got a surge response. You got an older patient, higher risk, and you got pleural effusions. That's going to be a really high risk patient. They'll probably be intubated. They'll probably be on pressors because they are getting complications from their pancreatitis. Okay, so complications we try to fix, all right, ahead of time, but ultimately we got to be alert to this worsening outcomes that may occur with someone with pancreatitis. So one of the complications of pancreatitis is chronic pancreatitis, right? So we were all talking about acute the whole time, right? So now once you got over acute pancreatitis, I think it's 50% of the time, now you have chronic pancreatitis. And this is not something that goes away. This is something you now have for the rest of your life, right? Until you get, are there such thing as a pancreatic pancreatic transplant? No. And so you now have pancreatitis for forever, right? Just like you have acute kidney injury and you can develop a chronic kidney injury afterwards, or chronic kidney disease afterwards, right? Or you have an MI, an acute damage to your heart, and you can develop CHF afterwards. It's kind of the same thing, right? You're developing a pancreatic insufficiency afterwards. It's like heart failure of the pancreas. Okay, so it's irreversible. So you cannot come back from this. You can't change your diet, take up yoga, and start exercising. That's not going to cure chronic pancreatitis. Okay, it's destruction and fibrosis of the pancreas, and we're going to lose the functions we talked about at the beginning, right? You're going to lose endocrine function, and we're going to lose exocrine function. So endocrine function was for glucagon and insulin, right? Glucagon, yes, it raises the sugar, but we have 4 other things that will raise the sugar, right? We get epinephrine, norepinephrine, we have cortisol, we have all kinds of growth hormone. All these things will raise the sugar. There's only one hormone in your body that will lower the sugar, and that is insulin. So congratulations, you now have diabetes, right? Because you have no way to lower your sugar anymore. So you're going to get diabetic complications. And then the exocrine function. So it's going to be on its last leg trying to squirt GI juices down into the duodenum, and it's not going to be secreting enough or not at all. And we have to replace those enzymes, the lipase, the amylase, the trypsin and such, right? So they're going to get a complication of steatorrhea. So yellow for floaty, right? Floaty, fat-laden stools that are the stinkiest stools you ever did smell, right? So like GI bleeds, like number 2. Steatorrhea is number 1, right? It's the most foul, floaty feces. because they are not absorbing the fats, right? You need lipase to break down the fats and to be able to, absorb it eventually. If you don't have lipase, you don't absorb it. You can have all the bile in the world to help it so the lipase can work, but if lipase isn't there, you're going to get steatorrhea. And you need fats to get absorbed with, or with vitamins, right? Which vitamins? The fat-soluble ones. Which are the fat-soluble ones? That's your A, D, K, right? B and C are water-soluble. Everything else is fat-soluble. Okay, so you have decreased vitamin absorption, therefore you get complications of that. So you get vitamin A retinitis, or you get, it actually causes stenosis of the biliary tree when you have vitamin A deficiency, which is not going to help. And then vitamin K, you're going to have clotting disorders. Vitamin D, you get some, there's inflammation that can happen, but also you get bone breakdown and such. So it's important to have your vitamins, right? So the treatment here is really just supportive, right? They might do some surgery to take out the pieces that have cysts and such that might be causing a lot of pain and discomfort. They get a lot of walled off cysts or walled off things that will occur that maybe they can try to take out, but that's not really much we can do. It's very, very supportive care. We will give them the vitamins, right, and the minerals, right, or vitamins and enzymes, I should say, to help them absorb the nutrients. But other than that, there's not much we can do. So what are complications that will happen from chronic pancreatitis itself? Well, that'd be pseudocysts. Remember, he said pseudocysts also have with acute pancreatitis. So 10% will develop an abscess afterwards. Now they have a chronic infection. Okay, they get obstruction of the flow, of outflow, so they get biliary problems. They get fistulas that form between the bowel. They can have infections that happen. Portal hypertension can occur because they get little thrombuses that, because it's inflamed and sclerosed, they can actually increase portal blood pressure and cause portal hypertension. And you get all the complications of cirrhosis just with a chronic pancreatitis. We talked about diabetes being a complication. We got pancreatic calcification, which is going to worsen over time. And this is a chronic pain syndrome. It has a lot of pain associated with it, so they can easily get addicted to pain meds. And they're going to hopefully see a pain doctor or a physiatrist to be able to manage the pain to an acceptable level with that stepwise protocol we talked about before. Okay, so the other complication of all this is pancreatic cancer. So you don't get pancreatic cancer from acute pancreatitis. You get pancreatic cancer from chronic pancreatitis, right? You get recurrent acute pancreatitis, and you're going to have a chronic pancreatitis in purple there, right? And then you're going to be at risk for pancreatic cancer, right? When you have gallstone pancreatitis, that's the one you want to have, because that doesn't really have the risk of developing acute pancreatitis in the future. That's usually why we did the CCY, which is a cholecystectomy, because that's going to put you, kind of save them from having another pancreatitis episode. So what do we do for these guys? So complaining acute versus chronic. So we give PERT. What is PERT? It's pancreatic enzyme replacement therapy. So PERT is a thing that we do to support absorption and improve their nutrition. And we know that we talked about the CT findings and the lipase elevation and everything with chronic pancreatitis, the acute pancreatitis, but what about chronic? It doesn't really equate to that, right? So imaging, you'll still see pseudocysts and such, but lipase, that's going to be acute pancreatitis. So it's not really elevated with chronic panc. Early chronic panc has that, or a lot of abdominal pain. They're going to have malabsorption. They're going to look really emaciated and cachectic. They're going to be someone that is, also a history of acute pancreatitis. But what else gets you to chronic pancreatitis without any acute pancreatitis? How do you skip steps? That's where you have alcohol abuse. That is going to put you at risk for chronic pancreatitis. Does alcohol put you at risk for acute? Yes. So it can independently make you have chronic pancreatitis. Okay, so what else? So acute pancreatitis we talked about in depth, but what are the differences? So they're all both have abdominal pain, but this abdominal pain with chronic is going to be persistent for a long period of time, right? And they're going to have ductal obstruction. They're going to have all kinds of other problems we mentioned, right? They're going to have portal hypertension as a complication because of splenic vein thrombosis that are occurring from the localized inflammation and localized clotting cascade that will be stimulated. And chronic pancreatitis puts you at risk for pancreatic cancer. Okay, acute pancreatitis had the complication of pseudocysts and necrosis, and chronic pancreatitis can get abscesses that form as well from these from their chronic states, right? So there's a classic triad. We talked about the triad for acute panc, right? They have lipase elevation, they got that classic epigastric pain, and they got CT findings. But for chronic pancreatitis, what we're looking at, they got calcifications. On the CT scan, they may be able to see on X-ray, but definitely on CT scan, you see this calcification that has occurred of the pancreas, right? And they have that. They got the steatorrhea. That's a classic part of our triad as well, right? We have steatorrhea. I can only think of like maybe 3 things that's happening, right? A, they're taking diet pills. B, they're taking their, it could be a gallstone. That's our gallbladder has been taken out because they're not producing bile as regularly. And then the other top 2 is going to be like Crohn's disease. And then we have our chronic pancreatitis. Those are like our top 5 for steatorrhea. Okay, and then what else? We got, pancreatic calcifications, steatorrhea, and we got new onset diabetes. That's really telling us we got someone with chronic pancreatitis on our hands. Okay, so ideally we want to kind of fix pancreatitis. Hopefully we fix it early, but avoid it from getting worse. But we have a 50% chance of acute pancreatitis developing into chronic pancreatitis, right? And then chronic pancreatitis can lead to chronic pain and lead to pancreatic cancer.